Okay, got it.
We're good?
Mm-hmm. Good.
Yeah, absolutely. All right. You're not muted. All right, we're good. Hey, everyone. I'm Dr. Chris Chadderdon, one of the hand and upper extremity surgeons at OrthoCarolina. We are back today with another webinar series. This month's topic is the Congenital Hand Clinic and an overview of what we do at the Congenital Hand and Upper Extremity Clinic. A replay of this will be posted to our Facebook as well as our YouTube channels. If you have any questions, if you're watching this live, feel free to drop them in the comments and I'll address those at the end. So we're just going to talk about a lot of what we do in our specialty clinic, the Congenital Hand and Upper Extremity Clinic here at OrthoCarolina. Just to give you a really brief history, we've had this clinic for about 11 or 12 years now. It started with these three folks, as well as myself. Dr. Wattenbarger's on the left. He was a pediatric orthopedic surgeon, along with Dr. Gass in the middle and Dr. Ozier. Dr. Wattenbarger left and went down to the Shrine Hospital in South Carolina. And then Dr. Woodside joined us, and this became our team. Over time, Dr. Ozier retired, and we were very blessed to have Dr. Waters join us from Boston, Massachusetts. He came down to join us about 2 or 2.5 years ago. And then finally, we've added Dr. Aversano, and now our congenital hand and upper extremity team is Dr. Woodside, Dr. Waters, Dr. Aversano, and myself. We see the full spectrum of congenital hand and upper extremity conditions. These are all examples of types of hand differences that we see in the office. We tackle them as a team together. We have a clinic once a month. It's the second Tuesday of every month. And we perform surgeries together as a team a couple of times a month to address these hand differences that we see. So just wanted to give an overview today of the general type of things that we see in the office and run through some examples. Probably take about 30 minutes or so. And just to give everyone a general idea of the spectrum of things that we see in this particular clinic. Congenital hand differences, and there's a bunch of different types, but in general, it's 1 out of every 500 live births. So it's fairly frequent, actually. And limb deformity is second only to congenital heart disease in terms of congenital differences. It's almost always spontaneous or inherited, meaning it's rarely teratogenic. So it's not due to something the mother or the father did while the mom was pregnant. So things that make it a little bit more common: advanced maternal age, pre and post-term labor, but almost 50% of these are associated with another anomaly, so a heart problem, a lung problem, something like that. So when we categorize the different types of hand differences that we see, this is one of the most common classifications that we see: failure of formation, failure of differentiation, duplication. And those are a lot of big words, and so we like to simplify it. And the classification is too short, too few, too many, too big, too little, too tight, WTF. The ones that come in and just they really don't fit any of the other categories, and we have to kind of figure out what to do with those. So first, yes, there are things that can happen during pregnancy that can increase the likelihood of a congenital hand difference. But again, these are very uncommon that we see. So the majority are spontaneous or congenital. Let's go to the first one, which is failure of formation, also known as too short. There are two types of failure of formation. One is transverse. Transverse means something stops growing perpendicular to the arm. And so that is like if you are born without an entire hand or mid-forearm or at the elbow. Longitudinal is when the difference or the absence is in line with the limb, meaning you're missing a portion of the thumb side of the forearm or of the pinky side of the forearm. And this is an example of that transverse arrest, meaning congenital amputation. And there are prosthetic options as they age. Really, there's not much to do when these kids are younger than 2 or 3 years old. And there are a lot of good prosthetic options as kids get a lot older. But the majority of these kids that are born with a congenital amputation or transverse arrest end up doing perfectly fine without any type of prosthetic, because that's the way they're born, that's the way their brain develops. And so we are always just amazed. I'm still amazed as kids get older, what they can do despite the difference that they're born with. This is one of the more common things that we see. This is a baby that was born without the radius bone. So there's 2 bones in the forearm, the radius and the ulna. And one relatively common condition is radial longitudinal dysplasia or radial longitudinal deficiency. You're missing a lot of the bone and the muscle and sometimes nerve on the thumb side of the forearm and even the thumb itself. This affects little boys a little bit more than girls. It's also called radial club hand. We don't use that term as much. That might be something that y'all have heard of. In the hand, the thumb is always affected, small or missing. And we'll talk about that more in a little bit. The wrist is most often flexed in a position like this, and crooked to the side like that, as you can tell from the x-rays here. And it comes in a lot of different levels of severity, meaning the radius might just be a little bit smaller, but the most common is the radius is completely absent. So the only forearm bone is the ulna. And even in these cases, the ulna itself is also affected. It's about 60% of the length. So it's important we tell the parents of these kids that the forearm is always going to be a little bit shorter than the other one, even though they still have that one bone in there. So the basic goals of treatment is to try to correct the alignment of the wrist and the forearm as much as possible, and essentially putting the wrist on top of the forearm. So we do that by releasing some of the tight structures on the thumb side of the wrist and literally putting the hand on top of the ulna and putting it as straight as you can, and putting it, you can see in that picture, in straight down the middle of the bone and into the wrist, hold everything straight. This is kind of a before and after. You can see the top picture is the before, and that's the purple ink is our line that we use to make an incision, our plan for surgery, and the bottom picture is the after. With these cases, yes, we're able to get the wrist very straight, but most often the wrist does drift back to being a little bit crooked as the kid grows old. And very often we have to do some other surgeries or touch-up work as the kid gets a little bit older. Thumb hypoplasia, which means thumb being smaller than the other side, or thumb being smaller compared to the other digits, that often goes along with the radial dysplasia. And it's on both hands, bilateral, 20 to 60% of the time. And with the thumb, there's several elements that are different. The bone, the muscle, the web space, meaning the space between the thumb and the index finger, and all the tendons in the thumb are either underdeveloped or not present at all. And so there's a categorization or classification system for thumb hypoplasia, all the way from type 1, which is it's just a little bit smaller, to type 5, which is the thumb is completely absent. You can see the spectrum of those. The top left picture is a type 1, where you can see the right thumb is a little bit smaller than the left, and you go all the way down across to the bottom, and you see the thumb is very unstable and floppy, if you will. Then we get to type 4, which we call a pouce flottant, which is for a floating thumb, and it's really just attached by a little bridge of skin. And the last type is type 5, which is an absent thumb. The way we look at this and how we figure out what to do is it's really interesting in these kids. They want to have a thumb. Their brain wants to have a thumb. The thumbs that either aren't there at all, or they're very unstable and very small and weak, the kids try to put things between their index finger and their middle finger, and they scissor the fingers like this. And the index finger actually starts to turn a little bit like it's trying to become a thumb. And so that really helps us make a decision to decide whether or not we should keep the thumb they were born with or maybe reconstruct and think about something different because the thumb that they were born with may not be very functional for them. So for the less severe types, like type 1, there's really no treatment. They have a slightly smaller thumb that works pretty well, actually. For the less severe ones, the type 2, some of the type 3s, sometimes we have to loosen up that web space, move some tendons around so the thumb moves a little bit better and unstable or floppy. For the more severe ones, the kind of the floating thumbs, completely missing thumbs, our treatment of choice is to take the index finger and turn it into a thumb, and that's called a pollicization of the index finger. We do these surgeries at least at 6 months of age, and we try to get to most of them before school age, in part just so they have a thumb before they get to school, but also we think that the brain does better learning how to use this new thumb if we do it at a little bit younger age. I'm going to skip these slides here. These are slides just about restoring some tendon function to the thumb with an opponentsplasty, borrowing a tendon from the ring finger and moving it over to the thumb to help the thumb move in this direction like the pollicization, making a thumb with the index finger, truly I think is my favorite surgery to perform. It is just a giant potential function of their hand. And to give a child a thumb where they don't have a meaningful thumb, it's just a big impact on our patients, the patient's parents, and it really is a big difference. So there are a lot of descriptions in how we do this surgery, but the basic principles are we cut everything except the nerves and the blood vessels, so that's the neurovascular bundles, the veins. We shorten the metacarpal bone because if you notice, the thumb is shorter than the other fingers. We don't want to take the index finger and turn it into a thumb that's as long as the index fingers. We shorten it a little bit. We rotate it, move some tendons around, and we pin it in the correct position. And this is the final result. If you look, there's 3 fingers now, and there's a new finger or a thumb in a perfect thumb position. And people don't paint fingers long term, and it's really interesting that people just don't notice when patients have a missing index finger. And this is kind of the final result. You have a thumb that can reach around and grab things, hold on to things, and pinch. And do they work perfectly like the thumb of the other hand? No, they don't. But are they a whole lot better on average than not having a thumb at all? Absolutely, they are. All right, moving on to the next category, which is failure of differentiation or too few. And this is another common one that we see. Too few meaning fingers are fused together, which is called syndactyly. Born with the fingers having shared skin, sometimes even shared bone and shared nail. And there's a whole spectrum of severity or types of these, all the way from a little bit of a skin connection, which you can see in this picture. Is showing up on that? Perfect. All the way to bone connected to the tip of the finger to these very complex cases like you see here on the left, where the fingers are kind of crooked and the bones are fused together. So these are all things that walk into our office. So here's kind of a schematic of the categorization that we use. Simple being just the skin is connected. Complex being the bones are fused usually at the tip together, and often the nails are converged or joined. Complicated cases are ones where the finger, skin, and the bone are all fused together. But there's also some crooked bones which are in the wrong direction in the hand. Most of these cases we do after 12 months of age. There are certain cases that we recommend surgery earlier, particularly for if the pinky and the ring finger are connected. If you notice, there's a much greater length difference between the pinky finger and the ring finger. And so if those are tethered at the end, it tends to make the ring finger a little bit crooked. And so we try to untether those or separate those so that the ring finger has a better chance to grow straight. Same thing for the first web space. If it's a connection between the thumb and the index finger, we try to open up that first web space at a younger age. So if they have a working thumb at a younger age, and also so that the growth of the index finger isn't limited by that by being attached to the shorter thumb. When we have these cases, a lot of times it's both hands that are affected. And most often in surgery, we perform surgery on both hands at the same time. We have two teams of surgeons that do that. And the benefit of that is a shorter duration of surgery, which means the child or the baby is under anesthesia for a shorter duration of time. We'll have 2, 3, sometimes even 4 surgeons working at the same time on both hands. We do our best with the web space. And there's a lot of different ways that we cut the skin to try to recreate a nice web space. And our results are actually pretty good at the most part. When the nails are fused together, we make these zigzag incisions just under the tip of the nail to try to recreate the nail fold. So you can see this skin right here where I'm pointing with my arrow, and this skin right here where I'm pointing with my arrow actually came from the undersurface of the nail here and here by making this incision. Most often, we need skin graft. If you think about it, if we measure the circumference around these two fingers that are together, that circumference is going to be less than if we separate the fingers and measure the circumference of the two fingers separately and add them together. There's about a 30% skin shortage. Now, we can use the elasticity of the skin to rearrange the skin a little bit to cover that defect or deficit. But most often, skin grafting or some type of coverage is needed. There's a lot of options for where we borrow skin graft, all the way from the pinky side of the hand to the groin to the forearm. So there's a lot of places that we can borrow skin from. Of late, we've had some better options with Skin Substitute, a product called Hyalo Matrix, and there's some other products on the market as well. And those are literally synthetic products that we peel open in a package in the operating room, and it saves the children from having to have skin graft borrowed from another part of their body. And so this is just one example of using this skin substitute for the first web space and for the space between the pinky and the ring finger. Now, it's important that we tell our patients, especially the parents, that when they come back in after 3 or 4 weeks, it looks like this. It always looks kind of goopy and wet, smells a little bit. This has been bandaged for 3 weeks. It always just kind of fills in with nice skin, or almost always, I should say. It just takes a few weeks for this to mature. So, but this is just a nice bit of before and after. This was some nice pictures borrowed from the internet, from EatonHand.com of some skin graft. And you can see the before and after. A more complex case is called Apert syndrome, which affects the hands, and you can also tell by the appearance of this child's face. There's also other syndromic, systemic effects of this syndrome. For the hand, this is a much more complex case, and very often all 5 fingers are kind of fused together. We call it a rosebud hand. And our goal with these kiddos is really to make 3-fingered hands, so thumb and 2 or 3 fingers. We try to separate out the thumb and get them at least 2 or 3 fingers to use. This is a more complex type of case as well. So next category, duplication or too many. So if you're born with an extra thumb or an extra pinky, which are the 2 most common duplications that we see. So top left, you can see an extra pinky. Top right, you can see a thumb that's kind of split near the tip. So all sorts of things. There's some famous people who have polydactyly. Hound Dog Taylor's a famous musician. Gemma Arterton, maybe mispronouncing it, is one of the James Bond girls. There's a lot of people who have polydactyly. So it's pretty common. There's a lot of different classifications, and this is for the thumb. So you can see moving from left to right, You can have just the very tip of the thumb bone is kind of split in two, all the way to the type 7s, where there's actually extra bones plus a split in two. The most common type that we see is a type 4. So there's one metacarpal, this bone here, which is here, and then the other two bones are split into two. And so just to show you some pictures, this is that type 1 where just the tip of the bone is split in two, and you can see the x-ray right here. There's a type 2, there's a type 3, and a type 4. So, really few thumbs down to the base here, and all the way to type 5, 6, and 7. So these are all x-rays from our office. Our goals really are to, in general, create one thumb. So to take the two and turn it into one that's stable. And we usually keep the ulnar thumb. So when we say ulnar, we keep this one right here, the one that's closest to the index finger. We really try to preserve, if we can, the normal web space here. And then we would remove this part, or this thumb, I should say. Sometimes we have to use components of the thumb that we remove and add to the part that we keep. It's important that we tell parents for the thumbs that there can still be angulation or crookedness down the road, like a zigzag deformity, even if we do a successful surgery. Sometimes the thumbs that we preserve are stiff. Sometimes there's nail deformity. Sometimes the thumb is unstable. There's up to a 25% revision rate. So that means that about a quarter of the time when you're doing a touch-up surgery down the road. What's also important to tell the parents is we think of this as not a true duplicated thumb. It's more of a thumb that was split into two. And the reason that's important to share is that the thumb that we keep, if we remove half of the thumb, or the thumb that we're not going to keep, the thumb that we preserve ends up being a little bit smaller than the thumb in the other hand, because it's a split thumb and not a duplicate thumb. And so, again, here's just a couple of case examples before and after where my arrow is, and before and after. So we're able to get thumbs that look pretty straight, look pretty normal, good cosmetic and good functional results. This is a unique case of a certain type of type 4 where the thumbs are zigzag, so they kind of zigzag out and back in towards each other. These are the ones that we do have to warn our parents, patients' parents, that down the road there's likely going to be a little bit of crookedness. Sometimes we do this surgery in 2 stages. So these are not all the same. What about the pinky side? So extra pinkies are pretty common as well. More common in Blacks and African Americans than Caucasians by a landslide. Most of the time, it's on both sides. 75% of the time, it's right in left hand. And 85% of patients born with extra pinky have a family history of it. And again, just like the other things we've talked about, it goes from a fully developed extra pinky to a little tiny one that you see on the bottom that's just barely attached by a skin bridge. What do we do with the ones that are just a little skin bridge, which we sometimes call the dangler, because they're just barely dangling on, right? It's almost like you could snip them off with scissors. Most of the time, we tie a little stitch around that. You can see that right here in the picture, there's a little stitch around the base of the finger, and that cuts the blood supply off of the finger. And then the finger turns into a little scab, like you see right here, and it just kind of falls off. And almost every time it works pretty well. Sometimes there's a little painful scar as the kid gets a little bit older, but the results are generally pretty good for this. And that's something we don't have to go to the operating room for. We do that in the office, usually even in the first few days of life. Next category is overgrowth, or gigantism is another term for that, or too big. And this is what we call macrodactyly. So macro means big or large. Dactyly means finger. These are examples of the index and middle finger too big. And the most common fingers are the thumb, index, and middle finger. That are most commonly affected by this condition. Sometimes we're able to do surgeries to debulk the finger and straighten the finger. So literally, removing some of the fat and the extra tissue. And when the fingers get about the same size of parent of the same gender, so if it's a little boy, when his index finger becomes as big as his dad's index finger, that's when we'd go in and try to stop the growth of the growth plates of the finger so that the finger stops growing and we debulk it as best we can. This is just an example of removing some of the tissue from the fingers to debulk it. Some cases are just so severe that the fingers are not reconstructible. And it's pretty dramatic looking. And really, looking different, these fingers just don't function well. They get in the way. It impedes the function of the thumb and the pinky finger. The best move here is often to remove these two fingers, so you're left with the thumb and two other fingers that can function reasonably well. All right, 3 more to go. Actually, it's 2 more to go, really. Undergrowth or hypoplasia, which means undergrowth or too little. And the thumb is the most common one, thumb hypoplasia. We kind of addressed that a little bit earlier with radial longitudinal deficiency. But you can get isolated thumb hypoplasia. The thumb is just a little bit smaller, and it's not associated with any other problems. It's not associated with the radius being missing or too short. And most often, the thumb needs length, and it needs the web space deepened so that the thumb can move away from the index finger. And our options for this are to do a surgery to deepen the web space. Sometimes we move the index finger on top of the short thumb. Sometimes we even lengthen the thumb bone. You can see in the bone picture here, there's a little external device called an external fixator. And over weeks, we lengthen a cut in the bone that we make. We can get about 2 or 3 centimeters of length that way. So this is an example, that example I just told you about. We distract or lengthen the bone 1/4 millimeter 4 times a day. So that's 1 millimeter a day. So that's 30 millimeters a month, which is just over an inch a month. And then occasionally we take bones from the toes, add them to the fingers if the fingers are a little bit hypoplastic or underdeveloped as well. So this is sort of a non-vascularized phalangeal toe transfer, meaning taking a portion of the phalanx from the toe and putting it in the finger. Again, just showing you some other examples of types of surgeries we do. And finally, the last one we'll talk about is constriction band syndrome. And so that is, its other name is amniotic band syndrome or amniotic constriction band. And this can affect really any part of the limb. It can affect the legs, the upper arm, the shoulder, the fingers, the wrist. And we often see these being multiple, meaning there's 1 or 2 in the hand, there's 1 in the leg of the same patient. It's about the same incidence in little boys and girls. About 60% of the time, there's some type of abnormality in the maternal gestation, meaning when the mom was pregnant. So, like I said, it's very common for there to be multiple amniotic bands in the body. The average is 3 bands in a baby that's born with an amniotic. The risk factors: premature delivery, low birth weight, maternal drug exposure, and if the mom was really sick or had any injury during the pregnancy. But these are not inherited, and these are not due to infection, to the best that we know. It's most common distally, which means closer to the tip of the fingers as opposed to higher up in the shoulder. It's often associated with syndactyly, which is the other thing we talked about, which is to fuse, which is fingers fused together. Sometimes the band is so tight that the part of the body, the finger, sometimes even the hand, because there's a band that was so tight during pregnancy, it comes amputated at birth. Sometimes it leads to swelling as well. So if you have a tight band around the forearm, sometimes everything beyond the forearm and then the hand can become swollen. We see that in the lower leg as well. Um, this can often be diagnosed with prenatal ultrasound, so we get a lot of our local OBGYNs who send us information. We actually see the mothers of some of these babies before the baby's even born to kind of tell them about what the ultrasound shows, so we can go through the options with them and tell them what to expect. Um, and then the treatment for this is usually at first it's observation. There's no reason usually to rush to the operating room, um, and the reason to operate is sometimes cosmetic, sometimes it's for function, quite frankly. Occasionally, these are emergent. If babies are born and the band is super tight, where it's compromising the blood flow to the arm or the hand, sometimes we do have to take these babies relatively quickly to the operating room to remove that band and kind of free up the blood flow to the hand. So, but most often it's elective, meaning 6 to 18 months of age. And sometimes we do this one big surgery. Sometimes we do two stages. So we'll go halfway around the arm or 180 degrees, and come back a couple months later and do the other half of the arm. But a single stage for the less severe bands like this kiddo here. That's pretty much it. So I'd like to thank my partners. We don't have an updated picture, so a couple have retired. There's a couple of replacements here. Dr. Aversano in the middle here, rear, filling on the right there. Um, but this is our group of hand and upper extremity surgeons at OrthoCarolina. And again, we take care of everything from shoulder to fingertip, um, and really love seeing people in the office. So I'd love to see any of y'all for any upper extremity problem you have, including the babies and kiddos with the congenital hand differences. So I would say about 10 to 20% of my practice is taking care of babies and pediatric injuries and congenital hand differences. I would similar profile for Dr. Aversano, who actually sees even a few more kids than I do. Um, so that's pretty much it. So happy to take any questions. And um, I'm going to stop sharing my screen as I've instructed. Yeah. All right. So we got a few questions here, and thank you for those. Um, all right. So one question is, what if a congenital hand condition weren't treated? That's a good question, one we get a lot. So some don't need to be treated, and so some like the thumbs that are only a little bit smaller, um, that, those don't need treatment. They don't need surgery. They don't need casting, bracing, splinting. The parents just kind of need reassurance that the hand is going to function great without any treatment. And on the other end of the spectrum, a lot of parents come in with a baby that's born with a different hand, and they decide that they'd prefer to let the baby grow up and not have any intervention. Have the baby grow into a child and the child grow into an adolescent without any intervention, and that's perfectly fine. Our job here and what we try to focus on is to present the patients and then the kids when they get old enough to really have a conversation about it with all the options. What are the options that we can do now? What are the options that if we wait, we can do in the future? So there's quite a few uh, babies and kids who choose through their parents to have an extra pinky or to live with a pinky and a ring finger that are kind of fused together. Some of these things can be addressed at a later age as well. So certainly, there's plenty of choice involved. Um, Next question is, are congenital hand conditions genetic? Yes, certainly some of them are for sure, especially the extra pinky that we talked about. Vast majority of those are genetic. Some of them are not, of course. Some of them, most of them are spontaneous, meaning it's just part of how the baby develops during pregnancy. Um, so, what is the biggest benefit of the multidisciplinary approach? Really great question. So when we have our clinic, our congenital hand clinic, we have 3 or 4 doctors or surgeons that are in the room, hand therapists there. We have a pediatric orthopedic surgeon who is kind of one floor above us, and comes down frequently because these kids often, like I said, have other problems, whether it's foot problems, knee problems, spine problems, and have kind of one-stop shopping where the kid and their parents can see all the orthopedic specialists that they might need in one office visit, is really helpful for time efficiency and for convenience for the patient and the parents. Um, and also that we can put all of our heads together, come up with the best treatment options and treatment plan for each patient. We rely on our therapists a lot, and our therapists are helping us with recommendations about splinting and exercises. Having multiple docs at that office is really helpful. We are all there together, and sometimes we go in and see patients all at the same time. Sometimes one of us goes in to see a little kid or a baby, then we come back out and we all talk about it together. We have a kind of group conference about almost every single patient that we see, so that there's multiple brains and minds working at the same time to try to come up with the best options for each patient. Very often it's a straightforward case and we all agree. Sometimes there's a lot of discussion about particular patients and particular cases. So some of great information. Thank you for that. What types of rehab and therapy are necessary for surgery for children? Great question. So that really depends on the surgery that we do. Most therapy that we do for kids, especially kids, is more just teaching the parents how to play with their kids or engage the hand in regular activities. Most young kids, you can't instruct them on how to do specific therapy exercises. They don't know how to do that. So simple things like restraining the good arm and having them eat food with the surgical hand, or playing with toys with the surgical hand. Play therapy is very common, and kind of finding toys and games that most benefit a particular condition. Our therapists also are really involved in making splints. So when we do surgery, we might put a cast or a bandage on the hand, and then the patient will come back in 3 or 4 weeks to remove the bandage. Very often they need a temporary they can take on and off that's custom fit for them, and that's something that our therapists are very helpful with and creative with as well. What advice would you give to parents of children diagnosed with congenital differences? Great question. Also, I think the most important thing that we try to share with parents is that everything else about their kids is important, and I think there tends to be a focus on babies who are born with something a little bit different, and it's really important that parents, not to focus on the one part or two parts that don't seem quite normal to them, and most importantly, give them hope, because kids are amazing, and as they develop and grow with a hand that's a little bit different, that's how their brain develops. It's with that hand that's different, and I've been doing this for 15 years, and every time I see kids in the congenital clinic, I'm blown away and amazed by what kids can do with the hand that they're born with, or without a hand, without parts of the hand, or with a hand that's different. And so kids really are versatile um, very able to overcome what we see as a pretty big deal. It's just the way they're born. And so kids will be perceived as different by their peers as they get older, but they overcome that with time. So the biggest 2 things is, one, take care of your child, other than the hand or the extremity that's different. Number 2 is your kid's going to do great in most cases, regardless of the hand that they were born with. How can someone watching this get in touch with the clinic for further information? There is a website. So on the OrthoCarolina website, there's a link to the OrthoCarolina Congenital Hand Clinic. And that's the best link, and there's information about some of the conditions that I just talked about. There's also a link to schedule an appointment, um, and, um, and then you can get in touch with our scheduler through that, both our clinic scheduler and if it ever comes to our surgery through that link. Do I need to know the exact name of the website? I don't know the exact. It's through the OrthoCarolina.com, OrthoCarolina.com. All right. I don't see any other questions. So thank you all for your time and attention and for attending. Remember, a replay of this will be posted to all of our social platforms. If you have any other questions, you have 20. I'm sorry, if you have any other questions, you can post those. And then remember that for any injuries, you have 24/7 access to an orthopedic specialist on the HURT app. So that's it. And hope everyone has a great rest of your day, and look forward to hearing from you all in the future.